In this particular section, we are going to discuss on the treatment of the bronchial asthma. Why I am discussing treatment in a separate video is the reason because the treatment is going to change, definitely. The treatment what I'm going to discuss right now is the new GINA 2019 guidelines. GINA, for your information, is Global Initiative for Asthma. So they are the gold standard for guideline makers, probably in the last 4 or 5 years. Before that, when we used to study, it's supposed to be the BTS guidelines, British Thoracic Society. Right now, GINA took over, and they are the ones who are the guideline makers, and they are the ones who are regularly updating the guidelines on treatment of bronchial asthma. 2019 guidelines saw major changes in certain areas, even though not that much major, but still it does have a major change compared to the previous 2-3 years guidelines. So let us move on to the treatment. Before going on to the actual treatment of bronchial asthma, it's better to know the severity first, like what we did in COPD. So because based on the severity only, we are going to treat the bronchial asthma. So severity wise, first you can classify this bronchial asthma into intermittent bronchial asthma, then persistent bronchial asthma. In the persistent, you have mild persistent, moderate persistent, and severe persistent. And there is no much change in the severity criteria, even though I like to make some changes based on the treatment aspects that have changed. First one, we can talk about the symptoms, and one more thing that correlates to the symptoms is the reliever use. So now you might be encountering a new word called a reliever. So what is a reliever? Because bronchial asthma component has two things, like you have a reliever and a controller therapy. Reliever in the sense, whenever they get a symptom, they use as a PRN medication. I told you PRN means Pro-Renata, where you use whenever you need it. That's what we call PRN. So this reliever medication is the one that's going to be used as a PRN medication. In the sense, whenever the patient feels like they are getting the symptoms, they will use it. That's it. So controller medication is the one that reduces the need for the reliever, which means the patient cannot be using 20-30 times reliever per day. So it controls the disease on the background itself. That's what we call a controller medication. Here, based on the severity, we have to see the reliever medications, because the more the number of reliever medications they use, reliever puffs of inhalers they use, more is the severity of the disease, which means poor is the control of the background disease. That's why they are using more and more relievers. Obviously, the symptoms are going to correlate with the number of reliever use. Previously, they used to call, even if you take the severity guidelines, they will mention as SABA use, that is short-acting beta-2 agonist use. But currently, there was some change in the usage of the relievers, because it was previously SABA, now it's LABA plus ICS. That's why I don't want to create a confusion. I'm just telling number of reliever use in a particular week or a month. Clear? Usually symptoms and reliever use in intermittent asthma tends to be less than or equal to 2 days per week. In mild persistent asthma, it tends to be more than 2 days per week, but not daily. But definitely not daily. Whereas in moderate persistent, it is almost daily, but not throughout the day. It's daily, but not throughout the day. Whereas in severe persistent, it is throughout the day. Throughout the day. Clear? So this is the idea. All right. Number 2, this is the most important. I'm going to tell a lot of other points also, but this is the most important that will be asked in exams. All right. The second point which we have to know is on the nocturnal symptoms. How much nocturnal symptoms is there for the patient, and how much nocturnal awakenings they are having. At the same time, how this disease is not allowing the patient to sleep in the nights. So that's a very important thing again. So in intermittent type, the nocturnal awakenings and nocturnal symptoms will be less than 2 per month, whereas here it will be 3 to 4 times per month. Whereas in moderate persistent, it will be more than 1 per week, but not daily. But not daily. Here, the patient will have daily nocturnal awakenings, which means they cannot sleep at all throughout the week. So this is what we refer to as severe persistent. And similarly, you have some numbers also. FE1 tends to be normal here, decreased. How much is decreased? Normal means, it is more than 80%, Decrease means it's in the range of 60 to 80%. Here, since it's severe persistent, it is less than 60%. Number 4, you have the FE1 by FEC ratio. Tends to be normal here, reduced. How much reduced? You know, normal means more than 70%, that is normal. So reduce means by at least less than 5%. Here, reduced by more than 5%. It's a little bit more severe reduction. That's all, FE1 by FEC ratio. And number 5, exacerbations. How much exacerbations you have? That we saw in COPD also. That's also one of the important risk factors. How much exacerbations we have here is 0 to 1 per year, which means not more than 1 per year, which means these patients are going to come under low risk. Here is going to be more than or equal to 2 per year. All these patients are a little bit at high risk. Whenever you call a persistent asthma, it's going to be more than or equal to 2 per year, little bit of high risk patients whenever you have more exacerbations. So this exacerbation is also very, very important. Number of exacerbations correlate with the severity of disease and even risk of morbidity and mortality also because of asthma. So the more the number of exacerbations, they are at a very high risk of death also. You have to be very careful about that. And finally, you have the recommended initial treatment. What will the initial treatment for these patients? Please note the word. I'm talking only about the initial treatment. Not this is the only treatment. Starting with this, depending on the response, you can step up or step down the therapy. Initially, what you will start. That's what I'm telling you. Be careful. So initially, you start with step 1, but still you can move up or down depending on the response. Here you start with step 2. In moderate persistent, you start with step 3. And in severe persistent, you are going to go for step 4 or 5 treatment. Clear? This moderate and severe persistent cases may need a short course of oral steroids or some systemic steroids. Usually we'll give oral steroids only. Any systemic steroid is fine. These patients may need a short course of oral steroids just to optimize them. Remember, bronchial asthma patients respond better to steroids compared to COPD patients. That point is also very important to understand. Let us see what's going to be the next thing. So next we have to see what are the stepwise approach. What are the stepwise treatment? That's what some changes are there in the GINA guidelines now. So let us see what you will do in step 1 treatment, what you will do in a step 2 treatment, and what you will do in a step 3 treatment, and what you will do in a step 4 treatment, and what you will do in a step 5 treatment. So let us see one by one. So in all the thing, you need 2 important things to understand, all the steps. One is the reliever, as I told you, and second is the controller, or otherwise maintenance therapy. So the reliever medication in all the steps is going to be the same, because this reliever medicine you are going to take as a PRN basis. Whenever you need it, you take it. That's it. So reliever medicine previously was the short-acting beta-2 agonist like a salbutamol, which is otherwise called as Asthaline by brand name, salbutamol puff. But right now, they do not recommend this SABA alone. Instead, they tend to move on to a LABA plus ICS as a preferred reliever. So this is the preferred reliever. This is the major change that was brought in the 2019 guidelines. Why this LABA plus ICS, they made it as a preferred reliever? Because this inhaled corticosteroids. I told you this corticosteroids is going to work wonders in an asthma patient compared to a COPD patient. They work really well for asthma compared to COPD because asthma inflammation is steroid responsive, that too in a great way. So that's why they wanted to bring this steroid early in the course of asthma, even as a reliever medication. At the same time, they found out adding this inhaled corticosteroid will reduce the risk of exacerbations. That too at the time of symptoms itself. The patient, now the symptom starts, slowly it becomes an exacerbation. But before it goes to the level of exacerbation itself, they can, down-regulate the exacerbation formation by giving an inhaled corticosteroid. That is the idea here. So that's why the current preferred reliever is going to be your LABA plus inhaled corticosteroid. But remember, suppose if the patient is taking SABA already as a reliever and they are very satisfied with SABA already, now you can ask this patient and counsel this patient to add an inhaled corticosteroid. That's why I'm telling the main idea of this entire change in the 2019 is to add a inhaled corticosteroid. That too early in the regimen itself, because they will reduce the number of exacerbations. That is the idea. Many trials have proven that. That's the reason why we have changed this one. Now we can move on to the controller. Controller therapy is the one that maintains the background disease and prevents the number of reliever use also. At the same time, it can prevent the possible exacerbations also. That's why this controller is very important, as I told you before itself. In step 1, you don't need a controller. Basically, you just need a reliever, that's all. In step 2, the preferred controller will be typically a low dose inhaled corticosteroid. At the same time, I didn't tell you one point, that in a reliever therapy, typically use a low dose inhaled corticosteroid. You don't use a medium or high dose inhaled corticosteroid as far as reliever therapy is concerned. So here you are going to do a low dose inhaled corticosteroid, or alternatively you can use a low dose inhaled corticosteroid with a LABA. Clear? So this is also advocated. Or third alternative you can use is a leukotriene receptor antagonist or a theophylline alone. Leukotriene receptor antagonist, for example, is Montelukast, which is very, very famous in India, or this alone itself you can use as a controlling therapy. But this is less preferred. You can put an order like this also if you want. This is the order of preference, so that will be less preferred actually. Adding I only Montelukast or theophylline. Or Zileuton is also there in this regimen, but since Zileuton is not common in India, it's not available in India itself in the first place. That's why I am not mentioning that. Or alternatively, you can even put a Cromolyn or a Zileuton. Cromolyn sodium or a Zileuton. Clear? So, but this all is not available in India, in fact, in the first place. Step 3, you can do a low dose inhaled corticosteroid plus a LABA. This is actually the preferred reliever for step 3. Clear? Or alternatively, you can prefer a medium dose inhaled corticosteroid also. This is also preferred. Or alternatively, you can try a low dose inhaled corticosteroid plus any one of either a leukotriene receptor antagonist like Montelukast, or you can prefer a theophylline, or you can prefer a Zileuton or a Cromolyn. But this combination is not valid. Again, preference is very less for that. But the preferred here is low dose inhaled corticosteroid plus LABA. Preferred in step 2, that is for mild persistent diseases, low dose inhaled corticosteroid only. For step 4 treatment, the preferred treatment will be a medium dose inhaled corticosteroid plus a LABA. So this will be the preferred. This will be the preferred medium dose inhaled corticosteroid plus a LABA. Clear? Or you can use a high dose inhaled corticosteroid here, but for this step it is not that preferred. Or you can use a certain add-ons to the regimen, whatever you use, either this regime or this regime, whatever you are using, you can use this add-ons along with the whatever regimen you are using. What are the add-ons? Typical add-on will be either a LAMA or a leukotriene receptor antagonist, that is Montelukast. LAMA, remember, is not that effective for asthma compared to COPD. LAMA is actually more effective for COPD than asthma. So anyway, you can use a long-acting muscarinic antagonist like tiotropium also. So in step 5 therapy, you are going to use a high-dose inhaled corticosteroid plus a long-acting beta agonist, that is LABA. Or alternatively, you can use a add-on therapies. Like, what are the add-on therapies you can use in step 5? Very commonly, the add-on therapy what we are going to use is the oral steroids, prednisolone. Oral prednisolone, very, very common add-on here. Short course will give. For some time later on, we'll taper it and we'll bring down to the basic. Or other add-ons will be your LAMA can be an add-on, or your biologicals also can be used as an add-on here. So you can see in step 5 treatment, your biological comes into play. That is a very important add-on for step 5. So here we have discussed about all the drugs. For example, we have discussed about so much drugs, like, what are the drugs that are used? You have the bronchodilators. Among the bronchodilators, we have the beta-2 agonists, we have the muscarinic antagonists, we have the phosphodiesterase inhibitors. At the same time, we have other drugs like leukotriene receptor antagonists, you have LOX inhibitors like Zileuton, and you have mast cell stabilizers like cromolyn sodium and nedochromal. All these things we have seen already in the COPD section itself. You can go and review if you want again. In the beta 2 agonist, we have a short acting beta 2 agonist and we have a long acting beta 2 agonist. These are very, very important treatment as far as asthma is concerned, because this is what we are going to use very, very commonly. Short acting beta 2 agonists like salbutamol and long acting beta 2 agonists like formoterol and salmeterol. Very commonly in India, formoterol is extremely common. And remember, this muscarinic antagonist is not that common in India. Typically, this SAManol is very, very rarely used. Only for exacerbations we use. And LAMA only as an add-on therapy, not a main therapy, because this LAMA are more effective for COPD than bronchial asthma. Typical LAMA we are going to use in India is the tiotropium, and there are many other types of LAMA are there which we have discussed extensively in the COPD section. Clear. Then phosphodiesterase inhibitor, one important thing that you have to notice, the only phosphodiesterase inhibitor that we are going to use is theophylline. Clear? In India. At the same time, the guidelines do not recommend the selective phosphodiesterase 4 inhibitors for the use of bronchial asthma, like roflumilast and cilomilast. Again, we saw in the COPD section. So you cannot use this PDE4 inhibitors, at least as of now. Selective phosphodiesterase 4 inhibitors like cilomilast and roflumilast, not approved for use in bronchial asthma. Only theophylline you can use. So you have limited options, like you can use SABA, LABA, theophylline, leukotriene receptor antagonist. These are the commonly used drugs. LAMA is rarely used. LOX, again, in India is not available. Mast cell stabilizers also in India, it's not available as of now. In many places at least. So these are the important bronchodilators that you have to know. Apart from that, you have inhaled corticosteroids. Inhaled corticosteroids are an integral part of the regime, one of the first line treatments in bronchial asthma. The importance of inhaled corticosteroids is so much in bronchial asthma compared to the COPD. In COPD, even in the last step, you are hesitant to add. But in asthma, in the first step itself, you first add inhaled corticosteroids. Very, very important. They reduce the risk of exacerbations. You have typically, you know very well, you have budesonide, then you have beclomethasone, and you have a fluticasone. Clear? So these are the important inhaled corticosteroids that you have. And only one problem with this inhaled corticosteroid probably is the risk of developing oral candidiasis, because you are using as a puff, and that risk can be reduced by washing the mouth or rinsing the mouth immediately after the use of the inhaled corticosteroid. So that is the one way where you can reduce the risk of this problem of oral candidiasis. But apart from that, they don't have any problem at all. They have excellent study backup, excellent response. They reduce the inflammation dramatically, reduce the risk of exacerbations, overall morbidity, mortality, everything is reduced by inhaled corticosteroids as far as asthma is concerned. So these are the important drugs. At the same time, you have to know the side effects of this beta 2 agonists. Very commonly asked questions in exam. So what are the side effects? I think we have discussed already in COPD. Still, I will tell you. The most important is the hypokalemia. And the hypokalemic effect is actually more with your IV or parentally administered beta 2 agonist rather than nebulized or inhaled route of beta 2 agonist doesn't cause that much hypokalemia, but still the effect is there. But parentally administered cause rapid hypokalemia. At the same time, they can also cause hyperglycemia. They can cause hyperglycemia. The mechanism is very simple. It is beta 2 mediated, and in the liver, beta 2 action may cause a enhanced glycogenolysis. Because of that only, you get this hyperglycemia. And this hypokalemia, you know very well already. The reason is intracellular shift of potassium, or it's called as transcellular shift of potassium into the cell, where the potassium is pushed from the extracellular side to the intracellular side, because the beta 2 agonists also activate the sodium potassium ATPase, which pushes the potassium into the cell. That's how. So it's a short lasting effect of hypokalemia, but still it's a powerful effect. Very important drug whenever you want to treat for a hypokalemia. And beta 2 agonist is also important for treatment of hyperkalemia, as already I told you, because since it causes hypokalemia, it can be used in treatment of hyperkalemia. It can be used as a treatment of hyperkalemia. At the same time, it can also act as a tocolytic agent. You know that. So these are the other uses of beta 2 agonists. But anyways, so these are the important drugs that you're going to use. Apart from that, there are a lot of biological drugs that are currently there. Lot of biological drugs are there. You don't have any biological drug for a COPD patient, but for asthma you have so much of biological drugs. The most important are anti-IG, and the drug that we know is omalizumab. And you have anti-IL-4 drug. IL-4 drug. The drug we have is two drugs are there. One is dupilumab and pitrakintra, but we are going to see only about dupilumab. In fact, it's anti-IL-4 receptor inhibitor. Then you have anti-IL-5. There are two drugs, both are approved. One is mepolizumab and another one is called as resilizumab. You have other drugs also, anti-IL-5 receptor inhibitors like benralizumab and anti-IL-13 lebrikizumab. All these drugs are not yet in the pipeline actually, but they are still found to be effective and approved in trials, but not yet in the pipeline for manufacturing and distribution in India as of now. These are the four drugs that are already available. So that's what we have to discuss, these four drugs. First, you have to know what are the age of approval for all these drugs. And your anti-IG omalizumab is approved for any patient with age more than or equal to 6. And your reslizumab is approved for any patient with age more than or equal to 12. And your dupilumab and mepolizumab are approved for any patient with age more than or equal to 18. So age bar indications you have to know. But remember, this is a major change. Why I'm telling you this is a major change is because previously, in the previous guidelines, it was more than 12 and they have downgraded the age bar to more than or equal to 6. So which means you can give a relatively more younger pediatric children also this omalizumab. And second thing is you have to know what route we are going to give. Route of administration, as you know, monoclonal antibodies cannot be given orally, obviously because they are protein fragments and will be destroyed rapidly in the stomach and the intestine. So the route will be subcutaneous for almost everything. Subcutaneous for almost everything except for the resilizumab, which will be given as an IV formulation. Apart from that, all these things will be given as subcutaneous formulation only. At the same time, what will be the method of administration, whether it is self-administered or whether it is administered in the hospital? Further to answer, this mepolizumab and dupilumab, these are the two things that can be administered as a self-administration, which means they can be given in home itself. But this omalizumab and reslizumab should be administered by a healthcare facility only. So they have to come to the hospital, healthcare facility or healthcare personnel only. They cannot take as a self-administration. This omalizumab and reslizumab. Next, what are the indications? Indications of use. As I told you, the first is the age indication. Already we have discussed. Apart from that, in any patients with moderate to severe persistent asthma who's having elevated IG, or if the patient is having skin prick test positivity, this is also equivalent to elevated IG only, skin prick test positivity. Similarly, this anti-IL-4 dupilumab indication will be obviously severe asthma. In severe asthma only we are going to use the biologicals. Plus, you should have an eosinophil count of at least more than or equal to 150 per microliter. Plus or minus, we can tell it as R, your fractional excretion of nitric oxide, that is fractional expiration, expired nitric oxide, that's what you're going to see. Expired nitric oxide should be more than or equal to 25 parts per billion. So this is a special guideline that you need to know. Apart from that, this anti-IL-5 as a common indication, that is mepolizumab and reslizumab, you know very well that these are anti-eosinophilic, which means they are going to prevent the proliferation and survival of eosinophils, anti-IL-5. So they can also be used in obviously in severe asthma. Plus, if the eosinophil counts are more than or equal to 300 per microliter, which means patient is a eosinophilic phenotype. So in those patients, anti-IL-5 may be very effective, this mepolizumab and reslizumab. So why I told you this is because since the entire world is moving towards the biologicals, so you have to know about the important indications of these biologicals also in asthma. Remember, but all these are approved for severe asthma. Remember, if you are having an allergic phenotype, that is IG based phenotype, you can give an omalizumab. If you are having eosinophilic phenotype, you can give a IL-5 like mepolizumab and reslizumab. If you are somewhere in between, not allergic, not so eosinophilic, we prefer a dupilumab. Very simple, not very difficult at all. So these are the things that you have to know about the biologicals. Clear? At the same time, we also have to know, we have known the different steps of treatment of bronchial asthma, but we also have to know that what is going to be the reason for either upgrading the step or downgrading the step. When will you step up the therapy or when will you step down the therapy? So when will you going to step up the therapy? Let us put an arrow. So if you want to step up the therapy, the most important indication will be your reliever use. If it goes by more than 2 per week. If the reliever use goes to more than 2 per week, which means the disease is going uncontrolled. So this is the one important indication that you're going to step up the therapy. Then if you want to step down the therapy, what will be the use? So there is no reliever use for at least 3 months. For at least 3 months period, you have never used the reliever, which means the disease is under total control. So this is the place where you can step down the therapy. So this is also easy to understand. And one more thing is there. This is upcoming. Something called an allergen immunotherapy. Allergen immunotherapy. So what do you mean by allergen immunotherapy? Which means we are going to sensitize the patient's body with giving allergen itself. That is what we refer to as HDM slit. What do you mean by HDM SLIT? HDM means house dust mite. SLIT stands for sublingual immunotherapy. So otherwise called as house dust mite sublingual immunotherapy. This is a very common and popular treatment in US. So indications for this is, if you are having a patient in step 3-4 treatment, plus they are having allergic rhinitis, one of the predominant problems along with the bronchial asthma. At the same time, if FEV1 is more than 70%, not be less than that. Less than that is also a problem. So more than 70%, because initially it might worsen the disease also. That's why we keep a target of FEV1 should be more than or equal to 70% at least. So if you match this criteria, then you can use this allergen immunotherapy as one of the potential treatments for controlling the asthma. Clear? Fine. So now we have to know how to control the exacerbations or how to treat the exacerbation. So we have to see treatment of exacerbations, especially an entity called acute severe asthma. This is a type of exacerbation, acute severe asthma. First of all, you have to know what is the definition of an acute severe asthma. For that, we can see how your exacerbations are classified. Exacerbations are typically classified as a mild to moderate exacerbation or a severe exacerbation. So the severe exacerbation is what we refer to as an acute severe asthma. So based on the symptoms, based on the clinical features that are seen in the patient, you can clinically itself grade. At the same time, investigations wise also you can grade the exacerbation into a mild, moderate or a severe one. So let us see. First, the shortness of breath. Shortness of breath here tends to be only during walking. Here tends to be at rest itself. Position, here the patient tends to sit. That's fine. Here the patient will be hunched over position. They cannot even sit. It will be severe breathlessness. What is the ability to speak? Here they can speak sentences and phrases. They can form a words in a phrase or sentence together. Here they can speak only individual words. They cannot form any sentences. They will be that breathless. And agitation? No. Yes, they will be agitated for sure. Then respiratory rate. Here both it will be increased only, but here it will be less than 30 per minute even though it's increased, but here it will be more than 30 per minute. Wheezing wise, uniphasic and monophasic, it will be only during expiration. Here it will be fixed, because fixed means it's more severe. Expiration as well as inspiration. Both you will see the wheezing. Fixed. They won't change the dynamics with your respiratory cycle. Then whether they use accessory muscles or not. Typically they don't use. Yes, there will be severe usage of accessory muscles here. Then pulse rate and heart rate, less than 120 per minute, more than 120 per minute. Tachycardia. Pulsus paradoxus typically absent, usually present. Pulsus paradoxus. Then partial pressure of carbon dioxide, less than 42 millimeters of mercury, more than 40 millimeters of mercury, which means as the severity increases, they are going for type 2 respiratory failure. That's why it is, because they're getting fatigued and exhausted. This indicates that the patient is getting fatigued and exhausted and they're going towards a type 2 respiratory failure, which is very, very dangerous in an asthma. Asthma patient should always behave like a type 1 respiratory failure during exacerbation. Your saturation, here it is more than 90%, here it is less than 90%. PFR wise, here it is 51 to 80%, but not more than 80%. Here it is less than or equal to 50%. This is a very important number, multiple times asked question. This is the PFR. Clear? At the same time, presence of cyanosis. So other features which will not be given in the book is presence of cyanosis, impending respiratory arrest, altered sensorium, altered mental status. All these things also come under a very, very severe or even a life-threatening attack. Clear? So this is what you have to do. So this is the way how you classify the severity of exacerbations. In that we are going to see how to manage acute severe asthma. That's a severe exacerbation. Point number 1, you're going to give oxygen because it's a type 1 respiratory failure. I told you, typically asthma is a type 1 respiratory failure due to VQ mismatch. We have seen that in respiratory failure topic itself. So give O2. And the saturation target, SpO2 target will be somewhere in the range of 93 to 95%. Remember in COPD, it is only 88 to 92%, but since it's a type 1 respiratory failure, there is no much problem. Maintain in the range of 93 to 95%, absolutely all right. There's no problem for me. And you have to give nebulizations. Initially, we prefer a SABA nebulization. You can do repeated SABA nebulizations. Typically, how much we can do is 3 doses, 20 minutes apart. 20 minutes. We give a repeat dose of SABA. So once SABA doesn't work, you can try considering a SAMA. And second one, you can add a oral steroid. This is done for all the patients. Almost all the patients we tend to add a oral steroid. Typical dose of oral steroid is prednisolone 40 mg for 5 days. Minimum 5 days we give. It doesn't mean you have to give only 5 days. Minimum 5 days. You can give for 10 to 14 days also if the patient needs more optimization with steroids. So oral steroids. Then you can try magnesium sulfate also. If this 3 doses doesn't work, then you can try a magnesium sulfate. Typical dose is 2 gram IV over 20 minutes. Why I told you this dose is because this dose is very different from TOS dose. In TOS point you use 1 gram IV, but here you are using 2 gram dose. That's why it's very important. But the effects of magnesium sulfate are little bit unpredictable. It's not really predictable. Then you can use epinephrine, adrenaline. And the dose of adrenaline is what is important. Remember, in anaphylactic shock, as well as status asthmaticus, that is acute severe asthma. Acute severe asthma. What is the dose of adrenaline I'm going to use is 1:1000. That's what I'm going to use. And it's going to be 0.3 to 0.5 ml. But in exam, go for 0.5 ml. That's the standard. 0.3 to 0.5 ml only. Or 0.3 to 0.5 milligram. That's what we're going to give. And typically, we are going to use in intramuscular route in anaphylactic shock, whereas we are going to use in subcutaneous route in acute severe asthma. But remember, it is completely different in your cardiac arrest. In cardiac arrest, the epinephrine dose is a little different, where you are going to use 1:10,000, 1 ml IV. So this is what you are going to use. Clear? So this is the usage of epinephrine in this acute severe asthma. You can try this subcutaneous, it really works to an extent. Then you can give systemic bronchodilators. Systemic bronchodilators. Systemic bronchodilators, you have IV aminophylline, but these are very highly arrhythmogenic. Be very, very careful. Very highly arrhythmogenic. IV aminophylline you can give, or you can prefer a subcutaneous terbutaline also. Subcutaneous terbutaline also. Both are highly arrhythmogenic and never mix with epinephrine. If you are planning to give an epinephrine, don't use both. Either use an epinephrine or use a systemic bronchodilator. but never give both. Both will add upon and will cause a life-threatening tachyarrhythmia and the patient might die. So don't give both. Then finally, still if the patient is not working, your treatment is not working, then you can go for a intubation and mechanical ventilation. Intubation and mechanical ventilation. So what are the indications for doing an intubation and mechanical ventilation? Number one is the cyanosis, altered mental status, which I told you already. If the saturation is less than 90%, PaCO2 rises to more than 40 to 45 millimeters of mercury, because an asthma patient should always be a type 1 respiratory failure. Whenever their CO2 increases, means they are getting exhausted and fatigue, and it becomes a type 2 respiratory failure. And if the patient is having inability to maintain respiratory effort, like how inability to maintain your push during labor is an indication for cesarean, the mother is getting exhausted. Similarly, here the respiratory muscles are getting exhausted if the patient is unable to maintain his respiratory effort. Clear? So remember, one important point to note that is NIV has a very poor role in treating asthma patients. There are multiple reasons for that. At your level, it's not important to understand. But NIV is generally going to have a very, very poor role in asthma. But in COPD, you have a very good role of NIV. But in asthma as such, especially during exacerbation, NIV has a very poor role because risk of pneumothorax and barotrauma is very high with NIV compared to your intubation. So that's why go for intubation itself in case of an asthma. So how will you monitor? Remember, asthma is a disease that is going to cause bronchoconstriction and airway resistance. So resistance is going to be very high. So the main thing that we're going to monitor, whether the asthma patient can be extubated or not, whether the asthma patient is responding to your treatment or not while the patient is intubated, is the fact that you are going to monitor PAP, that is peak inspiratory pressure. This peak inspiratory pressure is the one that's going to tell the resistance in case of a ventilated patient. I told you, isn't it, bronchoconstriction and resistance. Already we have discussed the ventilator topic, where you have this curve, which I would have taught you, just a recap. So here you do an inspiratory curve, or inspiratory hold, and this is what the pressure you get. This is what we refer to as a plateau pressure. When you do an inspiratory hold and you measure the pressure, that's a plateau pressure. Then I'm giving a quick recap. Go and see the ventilator section again. This pressure is what we call the peak inspiratory pressure. And the peak inspiratory pressure depends on two things. One is the airway resistance, and second one is the compliance. Which means your plateau pressure is directly proportional to the compliance, and your peak pressure is proportional to two things, because peak pressure is a sum of both compliance as well as resistance, and then only you get a peak inspiratory pressure. But in asthma patient as such, the lung compliance is not an issue. Usually the lung compliance will be normal only as far as asthma is concerned. So the only way to monitor the asthma patient, especially during acute extubation, and if they are intubated, means you would measure the peak inspiratory pressure, which will be a straight indicator of resistance as far as asthma patient is concerned, because their compliance is normal. So the only reason for elevated peak pressures will be your resistance of the airway. So monitor that. So that's why they will ask you what to monitor in a bronchial asthma during acute exacerbation. In an intubated patient, you have to monitor the peak pressures. That is the idea. Clear? Then when to discharge? Whether you will discharge the patient or when to discharge the patient. So discharging the patient is done when the PFR reaches more than 80%, that's a normal PFR, plus the patient is off nebulizers. Patient is not taking any nebulizers. So this is the standard objective criteria for a discharge. Again, it's based on a lot of subjective data also, but this is one of the very, very important objective criteria for discharging an asthma patient who has admitted for acute exacerbation or an acute severe asthma. So clear? So this is how you treat a acute severe asthma. So first you're going to go for nebulizations, then give O2 along with that, because many of the times O2 and nebulization are not a separate entity. We are going to use a O2 and nebulization together. In fact, the nebulizers that are run in asthma will run with O2 only. But in case of COPD, you should never run with O2. The nebulizers are actually done with plain air. Okay, O2, nebulizers, then add SAMA. If the SABAs don't work, then you can try magnesium sulfate, epinephrine, or even a systemic bronchodilator. Then finally, if there is no other option, you have to go for mechanical ventilation only after intubating the patient and monitor the patient with the help of peak inspiratory pressures. So these are the important things that you have to know about the treatment of bronchial asthma. And I only wanted to show this thing. So this is the one thing that is very important. This is a handheld one. You can use it in the home itself. This is called as Wright's peak flow meter. With this only you are going to find out the PFR. I think many of you would have seen this in the physiology lab itself in the first year. This is a peak flow meter. You have to blow as fast as possible, and it's a one-time thing. The maximum effort you give, they go and stop at some point. After that, it will not move. That's the peak thing that you can achieve. So this is calibrated already. This is a peak flow meter, and this is very, very useful, especially in homes when you want to monitor the bronchial asthma patient in home and all. So typically home monitoring of bronchial asthma is done through PFR only. The most important value for bronchial asthma patient is the PFR, peak expiratory flow rate. Whereas in COPD patient, you cannot monitor through PFR because of variable reasons. Instead, in COPD patients, we generally do it through FE1 most of the times. But in asthma, it's always about the PFR, most importantly. So I think that brings to the conclusion of the bronchial asthma segment. Suppose if there is any change in the 2020 guidelines in GINA, and if the major change, we'll update you with a new video.